Welcome to the EHJ Today at the ESC 2015 in London. My name is Julia Stehli. I'm a cardiology fellow at the University Hospital in Zurich, Switzerland. Joining me here today is Jean-Yves Heuzey, professor in cardiology at the University Hospital in Paris, Georges Pompidou. We're here to talk about the CeRtiTuDe Cohort study, which is now published during the ESC at the EHJ. Professor, can you tell me something about the rationale and the background of the study?
CeRtiTuDe is, as you said, a cohort study. In CeRtiTuDe, you recognize CeRTuDe. It's dealing with the problem of the treatment by devices of patients with heart failure. I mean, we know for many years now that when you implant a cardiac resynchronization therapy to some patients with heart failure, we can have a very favorable effect. But the discussion is always in our staffs when we see patients, is it necessary to implant also a defibrillator or not? In other words, is it CRTP, only the cardiac resynchronization therapy, or CRTP plus defibrillator, I mean CRTD. In fact, no real study, randomized clinical trial has been made to try to give an answer to this problem. When you look at the guidelines from the ESC, from the EHJ, HRS, there is no strict recommendation about the choice between CRTP and CRTD for these patients. It's why we have decided some years ago in France with the French Society of Cardiology to make a registry, a cohort study, to have an idea of the choice between the two categories of the patients made by the cardiologist, and also to have an idea of the follow-up of these patients and to understand how they die and what is the proportion of deaths in the two different populations.
And what methodology did you use?
So it's a methodology of a cohort study. In other words, it's not randomized, but we ask to all the groups who are participating in France in the cohort. It was 41 hospitals, electrophysiologist teams, to include their patients into CeRtiTuDe, whatever the choice, CRTP or CRTD. And we have, of course, a computerized data, and we have followed these patients for 2 years. And one of the main goals was to have an idea of the causes of death, and it's why we had adjudication to determine what was the cause of the death.
Okay, interesting. And what did you find?
We find in a cohort of 1,705 patients, followed for 2 years, as I said, that the profile of the patients were completely different. I mean, when you look at patients for whom CRTP has been chosen, we have found that it was elderly patients, older than the group of CRTD. There was more women. That's surprising, but we find again what has been shown in other conditions. More non-ischemic cardiomyopathies. More patients with more than 2 comorbidities. More patients with the most severe decrease in ejection fraction. And finally, also more atrial fibrillation patients. That's the profile for CRTP, and the opposite, of course, for CRTD. So very different profiles of the two categories of patients, the choice made by the cardiologist. As I said, there is no strict guidelines, recommendation to separate the two categories of patients, but in the ESC guidelines there is a small table with the different features which can be considered by the cardiologist to put one patient in one side or the other one. And when you look at this table, it's very close to what we have found. In other ways, I think that French cardiologist, I cannot say follow the recommendation because it's not a recommendation, but have the same analysis as the group who has made the recommendations about defibrillation and CRT.
Okay, and but what kind of implication does these findings have for the future and also for the clinicians?
The second part of the work, which is very important, because you know there is an European survey which has been made some years ago, including, I remember, 2,000 patients, showing almost the same data. So in other words, in France we are just in the middle of what is made in Europe. But what we have done is to follow the patients for 2 years and to try to determine, as I said, the causes of death. And here we have a surprise, which is the following. In fact, in the CRTP group, patients without defibrillator, more than 95% of patients die from non-sudden death. In other words, that shows that it was not really necessary to implant a defibrillator in these patients because they would have probably no benefit, except 5% of them. So the question is the following. Is it necessary to put CRTD with a defibrillator to all these patients if they don't die from sudden cardiac death? Because they are dying from progressive heart failure. And the defibrillator would have not been a benefit. It has also an important implications, which is a medico-economic one, you imagine, because the cost of the CRTD, of course, it's much higher than the cost of CRTP. So I think that's why this registry, this cohort study was interesting and important, because we were lacking of randomized clinical trials on these subjects. The only one which had not tried, but a little dealt with this problem was Companion. In Companion, there was an arm with a comparison, but the trial was not designed to demonstrate the superiority of one to the other. So it was not possible to conclude, and it has been made in the guidelines saying that we cannot conclude. So this registry, this cohort study, shows that the choice of the French cardiologists are in accordance with what have been proposed by the group of the ESC making the guidelines, and that I have to be clear, the mortality of the CRTP patients is higher, about twofold. Of course, because they are older, because they are more severe, and so on. So if you want to decrease the mortality, CRTD is better, but it's clear that category of patients would not benefit from a defibrillator.
Yeah, but you think it's still necessary to do like prospective randomized trial?
Yes, I wanted to come to this point.
Yeah.
It's a pity if this trials has not been made because it could have been interesting, but it's difficult to find grants to do that because you imagine that. Yes, you have understood everything. It's not very easy for the industry to propose such a trial. And when you look at the proportion of CRTD and CRTP in the different countries, it's clear that in the US, it's a very, very large majority of CRTD. And it's depending on the countries, but the mean number of Europe is around 75% for CRTD and 25% for CRTP. But your question, of course, is interesting because, yes, there is still a room for CRTP, and I think that it remains necessary to make randomized clinical trials, perhaps not in all the population, but in selected population to really randomize between CRTP and CRTD. Another difficult problem is to know what to do when you implant a CRTD in the patients for whom you will see an increasing, an improvement in the ejection fraction when you have to change the device. So you have to let the CeRTuDe on to come to the CRTP, because in many cases the patient is older. That's also an interesting question which is pending, and for which we have not real answer to date.
So very short take-home message for the audience.
There is still a room for CRTP. It will be necessary to make randomized clinical trials, but when you look carefully to the different, not guidelines, recommendation of the ESC in the guidelines, you can make your choice between CRTP and CRTD, and because it's clear that some CRTP patients will not have benefit of the defibrillator. And finally, the point is that it has also a medico-economic interest to avoid to implant not really useful defibrillators.
Thank you very much for the interview.
Thank you.